So for day 9, I want you to continue with infections. So you've done all of the antibacterial content. So now I want you to focus on infections with antivirals. So viral infections, herpes simplex infections, understanding HIV, varicella zoster, chickenpox, herpes zoster, shingles, antiviral drug choices, influenza, and introduction to COVID-19. All of this is available on your platform. If you're a member, if you're a non-member, I just want you to go through these topics in this particular order. And I will also have some questions. We're going to go through a quiz night tonight in tonight's video. So following on from once I complete this, we'll start with some GPhC style quiz questions. For infections, I want you to also go through antifungals, go through fungal infections, aspergillosis, candidiasis, amphotericin B, itraconazole, voriconazole, ketoconazole. Understand the differences between the azoles and also the differences between the safety considerations, because this is how you could be questioned in the assessment. And then in relation to calculations, I want you to go through 12 different examples. So calculations module 5, so 12 different example questions, one from each type of question for the GPhC exam. Now let's get started with tonight's GPhC style quiz night. So hopefully you find today useful, and I will see you tomorrow for the next one. So the GPhC exam is a 2-part assessment. You've got paper 1 that consists of 40 calculation questions, and you've got paper 2 that consists of 120 questions, 90 of which are single best answer, 30 of which are extended matching. Part 1, you have 2 hours to complete it. Part 2, you have 2.5 hours to complete it. A calculator is permitted for part 1. It's not permitted for part 2. Of course, you're thinking with regards to this, why is it not permitted? It won't be needed for part 2, but you can have calculation questions. But the only stipulation with regards to this is you have to do them without a calculator. With regards to recordings are unfortunately for members only. I do open up free attendance for these sessions, but the recordings are for members only. So I upload them to the members portal after the sessions. With regards to assessment framework, there's 3 tiers for weighting. There's high weighting, which makes up to 60 to 70% of the questions, medium weighting, 25 to 35% of the questions, and low weighting, which makes up to 10% of the questions. Today, we're going to focus on 2 topics in particular. We're going to focus on the endocrine system and the infection chapter. Okay. So there's going to be a giveaway from today. All you have to do to enter the giveaway is just take a snap from today's session and tag MicroPharm on Instagram, and you will get a free question pack with 25 GPhC style questions. Let's get started with the first question. Read the next question. Mrs. Insulin, 32, has been newly diagnosed with diabetes. She's struggling to remember her targets. She walks into a community pharmacy and asks you, what should her target fasting blood glucose be when she wakes up? I'm going to share the answers now. So a lot of people have picked 4 to 7, and upon waking, it should be 5 to 7. The only time it should be 4 to 7 is any other time in the day before meals. And I think that's what's led to the confusion. An easier way to remember it, and a way that I teach people, is if you want to remember it, just think of it this way. If the target was 4 to 7 on waking, and you're telling a patient to target 4 to 7 on waking, what is the risk during the night? Absolutely, the risk is hypoglycemia in the morning or during the night. And it's hypoglycemia can lead, there's a lot of deaths associated with hypoglycemia during the night. So it's something that needs to be taken into consideration. And it's something that should not be taken lightly. And therefore, the target is slightly higher on waking compared to any other time of the day before meals, because you have much more control of your sugar levels during the day when you're awake. The next question, Miss Sweet, 45 years old, is type 2 diabetic. Her HbA1c has increased since her last diabetes review. She's going to be commenced on new medication. She's currently on metformin alone. Her past medical history is as follows. Which of the following agents is contraindicated for Miss Smith? Okay, let's share the answer. The large majority of put down pioglitazone. which is correct. Pioglitazone has a cardiovascular safety warning where there's an increased incidence of heart failure associated with pioglitazone. In particular, I'm more concerned when it's in combination with insulin. However, there's a strict contraindication for giving patients with heart failure. For example, Miss Sweet has left ventricular heart failure, as you can see over here, for giving them pioglitazone because it can exacerbate the heart failure. So very important to take into consideration. Let's move on to the next question. The next question is about Mr. Sucrose. The GP wants to commence him on sitagliptin. This is renal function. I'm just going to get you a link, the BNF monograph, which you can use for this question. So let me pop that in the chat box. Here you go. EGFR is 41 milliliters per minute. What should the dose be? Okay, I'm going to share the answers. The large majority of you got this right. It was 50 milligrams once daily. So you can see the dose adjustments in the renal impairment section. And you can see that if the EGFR is between 30 to 45 milliliters per minute, then you should reduce the dose to 50 milligrams once daily. Moving on to the next question, a 53-year-old patient with type 2 diabetes has commenced on a new medication for his diabetes. He's advised by his GP that there's a rare risk of diabetic ketoacidosis. Which of the following is he likely to have been prescribed? Someone asked a great question as a direct question and said, how many questions use monographs or additional resources? So the GPhC state in the framework that up to 25% of questions in part 1 and part 2 can include additional resources. So it's up to 25%. So it's something to take into consideration, and it's very important to familiarize yourself with the BNF monographs and also familiarize yourself with EMC monographs for different medications. So the SPC, so the summary of product characteristics for different medications and what the numbering exact for the subheadings for each of the categories, so you know exactly where to go if you're looking for renal impairment, exactly where to go if you're looking for liver impairment or storage conditions. So something to practice and under time constraints. Very important. Let's share the answer from this question over here. The correct answer was B, canagliflozin. There's a rare risk of diabetic ketoacidosis with SGLT2 inhibitors, and this should, of course, is an important aspect to take into consideration. So you can find this MHRA warning. You can find this MHRA warning in the BNF monograph. Moving on to the next question, a 54-year-old patient walks into the community pharmacy. She's concerned because she's read a report that it can increase the risk of bladder cancer. Which of the following is this patient likely to have been prescribed? Okay, let's share the answers for this question. This again was pioglitazone. So pioglitazone, there's quite a few considerations with regards to pioglitazone. The initial consideration is increased incidence of heart failure, and therefore that needs to be taken into consideration. And also there's a rare risk of bladder cancer associated, a possibility of bladder cancer associated with pioglitazone use. So you can see this extract here is from the BNF monograph. Okay, this will be a very interesting question. And this is something that I've got some inspiration from a GPhC sample question. So it'll be very good to know how people perform in this. A patient received 4 doses of gentamicin, 120 milligrams by IV infusion over 60 minutes every 12 hours for bacterial endocarditis. They provide you the peak, target range, and the trough. And the peak for this particular patient is reported as 2.3 milligrams per liter 1 hour after the administration, and the trough is 0.7 milligrams per liter just before the next dose. Which of the following is an appropriate method of dose rationalization? To you this. The only thing I've changed is the values and the dose, but everything else with regards to the question is similar to a GPhC sample question that they've actually an official GPhC sample question that they've put. Let's lock in your answers here. I'm going to ask you some questions. So I've locked in your answers and I'm not going to share it yet. I'm going to ask you some questions just to gain your understanding of this question. So what is a peak gentamicin level? What does that peak level mean? What is that telling you? The highest concentration in blood, so the dose after, strictly speaking, the dose after an hour of administration, and you'd expect that to be the highest concentration of the drug in this patient's blood. So this is the highest. What is the trough telling you? And in essence, what is it telling you? What are you trying to identify? So in the amount left in the body following clearance by the body. So you want to see, is this patient's body clearing the drug correctly? Meaning they're not retaining more than you'd expect. And if they're retaining a lot, you're worried about clearance of the antibiotic, and therefore you're worried about accumulation. So how much are they actually absorbing, and what's the highest concentration of that? So are they getting enough of the medication? And the trough is telling you, are they getting rid of enough of the medication? It's that simple. So let's look at the values. The peak gentamicin level is reported as 2.3 milligrams per liter. Question, are they receiving enough of the medication if this is their peak? No, very good. They're not receiving enough. Our target is between 3 to 5 milligrams per liter. Next question, trough is 0.7 milligrams per liter. Are they getting rid of enough of the medication? Or do we have any concerns here with this value? Yes, sorry, I've given you two questions there. Yes, they're getting rid of it, the medication. We have no concerns with them getting rid of the medication. So we have no problem with the trough. And do we want to change anything with regards to this trough level? Do you want to make any changes to this patient's regimen with regards to the trough level, not with regards to the peak? No, we are happy. What would we be happy with? What would we be altering if a patient's trough level is too high? The dose or the dosage interval? Dosage interval. Does everyone understand that concept? If you don't, let me know. I'm happy to explain it. Otherwise, because I'll move on to the next point. Everyone understand that? Anyone that doesn't understand that concept? No. Okay, there's a few people. So what you're looking at is we're giving one dose here, and then 12 hours later, we're giving another dose. If 12 hours later, the trough level is higher than 1 milligram per liter for this patient, that means they're not getting rid of enough of that antibiotic in 12 hours. Therefore, the strategic thing to do, if that trough level is too high, is to increase the dosage interval. Because this patient's level is less than 1 milligram per liter, we are happy with this trough level, and therefore we're not going to mess around with dosage intervals. We're going to keep the same dosage interval because of that. The peak level, however, means the patient is not at its peak. The patient is not receiving enough of the antibiotic. So what do we want to do with the dose with regards to this peak? We want to, Mark, we haven't gone through the answer yet. That's the only, don't worry, I will go through that. So we want to increase the dose so that that peak level is between 3 to 5 milligrams per liter. And we want to keep the dosage interval the same because the patient's getting rid of enough of the antibiotic before the next dose. So the correct answer is C, increase the dose and maintain the same dosage interval. I will include examples like this in following webinars with different examples where I mess around with the trough and mess around with the peak so that you can have different answers, and hopefully you can show and demonstrate your understanding of these questions. So we have an 86-year-old patient that presents with a fever and several watery bouts of diarrhea. The microbiology lab identified the C. difficile toxin in his stool. He's previously been treated with vancomycin for C. diff 7 weeks ago. What should he receive? This is a tough question. Let's go through the answer of this. So, in terms of treatment of C. difficile, the main agents that are going to be used is either oral vancomycin or oral fidaxomicin. Oral metronidazole is no longer recommended on any of the guidance nationally. So I'm going to put the correct answer here is fidaxomicin. I've included the guideline here. So if it's someone's first episode and it's either mild, moderate, or severe, your first line, don't worry, I'll go through the answer. So if you've missed the answer, I'm just going to break down the guideline first. So the first line option is vancomycin, and your second line option is fidaxomicin. Now, the difference here is this is a patient's further episode. They've already had an episode of C. diff, managed for C. diff 7 weeks ago. So then the question is, if it's a further episode, is it within 12 weeks? So you would consider that a relapse of the initial infection? Or is it after 12 weeks, where you say this is a recurrence and this is not a relapse of that initial infection? Therefore, if it's a recurrence, if it's after 12 weeks, you can give vancomycin or fidaxomicin. With this question in particular, it's after 7 weeks, so it's within 12 weeks. And therefore, your other option is fidaxomicin orally. Something that's very important is vancomycin IV is not recommended at all. And that's because it's such a large molecule, it will not make its way into the gut if you give it IV. So you give it IV, it can't make its way from the blood into the gut because it's too large as a molecule. So that's why IV is not recommended for the treatment of C. diff. So the correct answer here is fidaxomicin, which is D. Let's move on to the next question. So you've got a 65-year-old male patient diagnosed with hospital-acquired pneumonia. They have a blood pressure of 88 millimeters of mercury systolic and 70 diastolic. Penicillin allergy, nature of the allergy is anaphylaxis. Which of the following is the most suitable antibiotic to treat this patient with? Let's share the answer here. So the large majority of you have put down doxycycline. There's two reasons why doxycycline would not be appropriate for this patient, given this patient's history. Can anyone let me know what those are? Signs of sepsis. Absolutely. So the patient's got two signs of sepsis here. So the correct answer is D, levofloxacin. But I'm going to let you know why. There's low blood pressure and acute confusion. And when you look at the guidelines, these are signs, severe signs or symptoms associated with hospital-acquired pneumonia. And therefore, you can only treat a patient with signs, septic signs, where you know the source of the infection is pneumonia, chest. You can only treat with IV options. Doxycycline is not given IV. And therefore, your only option here is levofloxacin from the options you have. And the reason for that is you've got coamoxiclav, which you can't give because of the penicillin allergy, or amoxicillin. Nitrofurantoin will accumulate in the bladder. It's not what you need for a chest infection. So it's between doxycycline and levofloxacin. Patient's got severe signs and has to be treated with IV. Your only IV option is levofloxacin for this patient. Question number 9, a 45-year-old male patient is diagnosed with low severity community-acquired pneumonia, has a penicillin allergy, develops a rash when they take penicillin, which would be the most suitable antibiotic to treat this patient with. So with regards to the question in the chat, do we need to learn the treatment options or severities? So it's very important to have an understanding of why one treatment is chosen over others. There have been circumstances where they ask about the treatment options for a patient with mastitis, for example, and they had expectations for students to know, training pharmacists to know about the treatment options for mastitis. So they want you to know about the appropriateness of prescribed medications. So they may say that this has been prescribed for a patient for X, Y, and Z, and assessing the appropriateness of those prescribed medications. They want you to understand the purpose of guidelines in accordance with the GPhC framework. So I would say have a good understanding of common infectious diseases that are treated with, I'm going to share the answer from this question. The correct answer is C, doxycycline, because of the penicillin allergy. So we go over here to the severities. If a patient cannot have amoxicillin for low severity, they can have doxycycline, clarithromycin, or erythromycin. This question, I would say, is more in line with the difficulty levels associated with the GPhC registration assessment. And the final question for today, we're going to go through this question, and I'm just going to pop some important links for you in the chat whilst you're answering this. So you got a 33-year-old female patient with a lower UTI. She doesn't have any allergies. She's not pregnant. What should she be treated with? Let's share the answers from here. So it was between two options, nitrofurantoin and trimethoprim. No one's selected anything else. The only reason why trimethoprim is preferred over nitrofurantoin in many guidelines, so many national and local guidelines, is because of resistance. So the only time you'll be giving trimethoprim is if the likelihood of resistance is low. In some localities, nationally, 1 in 3 patients demonstrate resistance to trimethoprim. In some localities, it can be 40% of patients. The E. coli identified from patients demonstrates resistance to trimethoprim. And that's why in many cases, nitrofurantoin is the preferred option to trimethoprim because resistance is much lower. And that's why if you consider back to single best answer, the more appropriate option is nitrofurantoin for this patient. Doesn't have any allergies, is not pregnant, the most suitable for this patient, nitrofurantoin. So let's see how many questions you got right before we end today's session. These are anonymous, by the way, so if you're reluctant to answer, I cannot see your answers. Someone is asking a private question, so I'm not going to say who it was, but with regards to allergies, if a patient has an allergy that's a rash to penicillins, does that preclude amoxicillin? Yes. So if it's a true allergy, so if it's stated to you that they have an allergy to penicillin, you consider it a true allergy. If that's the information that you have. So if it's a true allergy to penicillin, it precludes amoxicillin. There is times where it may not be a true allergy, and that's where they may ask you a question to determine whether or not something is a true allergy to penicillin. And that could be, for example, understanding. So one of the common misconceptions is students, trainee pharmacists not understanding that nausea or vomiting associated with amoxicillin is not a true allergy, which I'd expect the large majority of you to understand. So this is a common mistake that people make, is they don't identify what is a true allergy. The question here wasn't whether or not for you to identify if it's true allergy. I'm telling you that there's a rash associated with penicillin, therefore that precludes amoxicillin. Let's share the answers. So bit of a mix. About 30% of you got between 4 and 5. About 40% of you got between 6 and 7, and 20% of you got between 8 to 10. So I think that was a good mix and a good range of questions, and hopefully you found that useful. We're going to close today's session here. If you want any of the important links, if you want to give feedback, anything at all, and any freebies, just click any of these links over here. I will close this session now. I will stop.